The other clinical relevance and a concept that is now talked about a little bit more is functional anteversion. We know what anatomic anteversion is, and that is the reference of the postiocondylar axis of the knee to the femoral neck. But functional anteversion is something different, is where the patient is in the coronal plane, which is the red line. So you can see the functional anteversion of this particular is different than the anatomic anteversion, and it can be influenced by reconstructing of the hip. And that's the earlier concept where we talked about in-toeing and out-toeing. So the aim of this study was to assess the relationship between femoral version and the axial rotation of the femur before and after total hip replacement. We looked at 2,000 CAT scans, did the analysis, and then had 59 patients where we got a postoperative CAT scan to redo the analysis. In the pre-op area, you could see that a retroverted femur, just like we described earlier, causes some out-toeing. An overly anteverted femur causes some in-toeing, which we would expect. It was interesting to see that decreasing the version caused femoral external rotation or out-toeing. Increasing version caused femoral internal rotation or in-toeing. And it makes sense, because if you look at this diagram right here, it's the soft tissue around the greater trochanter that's just trying to pull the greater trochanter back to its original position. You can see the native hip on the left. In the center, the version has been changed, and the soft tissue pulls the greater trochanter back into its original position, which causes in-toeing of this particular patient. So recreating native version with total hip replacement may be beneficial to avoid change in functional anteversion, to avoid change in foot progression angle, and to avoid the change in the contact patch after total hip replacement. So we currently use a neck-preserving implant, which we do believe has a better chance of recreating the proper anteversion. And we actually did a virtual, so this would be a low anteversion, this would be a high anteversion, and we actually did a virtual implantation study, which was quite interesting, with a neck-preserving implant. And you can see that when we looked at X, Y, and Z, which is offset leg length and anteversion, the numbers were much smaller than if we used a conventional implant where the variability was much larger. So in conclusion, offset and leg length is important. Anteversion is highly variable and important for implant survival. Anteversion is different between female and male and may change with age. Femoral implant version varies greatly. Femoral implant version can change greatly in either direction, regardless of surgeon's philosophy or implant utilized. And a neck-preserving implant may better reconstruct femoral anteversion. So in summary, I think functional and anatomic cues are important. The right implant at the right orientation for the right patient, and we do live in a world of 3D. So as Albert Einstein said, we cannot solve our problems with the same thinking we used to create them. Thank you very much.